Arun. Thank you, respected chairpersons, and good evening, everyone. Of course, I cannot move on without thanking my dear friends, Dr. Manoj, Purvi, and Bansi sir for having me here, part of DRS. Always a pleasure. Um, this is the next couple of minutes. I'm going to be talking about the newer generation prandial insulin, namely the ultra rapid acting Lispro. This is a sponsored session supported by Cipla. So we know that our part of the world, the postprandial blood glucose is a burden for many reasons. One, because genetically itself we are beta cell deficient, insulin deficient. Beyond that, if you see, look back at those pictures there on the wall about, it's all, our diet is all about carbohydrates, isn't it? So it is quite a challenge to control that postprandial blood glucose, which in turn contributes to not just an uncontrolled HbA1c, but we also now do know that it has been well accepted that postprandial glucose excursions can increase the risk of complications, both micro and macrovascular complications. And this in turn can also lead to worsening of TIR or time in range, which we know increases the risk of complications, increases oxidative stress, and so on. This is a consensus guideline. So due to this, of course, we generally do have our international guidelines, but we do have specific guidelines, Indian guidelines, to address the postprandial blood glucose. And the importance has been stressed on these guidelines, and this itself shows us that it is important to reduce that postprandial efficiently. This is also recently we know that there has also been some importance on the 1 hour blood glucose. We know that earlier we've always been looking at the fasting and the 2 hour postprandial, but the 1 hour also we have now come to know that it is important in contributing to that rise in HbA1c, and we never used to check much for this, but in our practice now, of course, we have started incorporating it, if not in our daily practice, but in some patients where it may be applicable. So that being said, as a context, what are the tools that we have? We know that postprandial blood glucose is important. We know that targeting the post-meal peaks are important. This in turn will reduce risk of complications. But what are the tools that we have to tackle these burdens, and what are the tools that we have available? So most of the prandial insulins that we have today, unfortunately, do not exactly, does this pointer work? Doesn't seem to work. Most of the prandial insulins, can I get a pointer, please? Most of the prandial insulins that we have today do not match the postprandial peak that we have, simply because they do not match the first phase of insulin secretion or the physiological peak of insulin secretion that we naturally have to handle the postprandial peak. And this is one of the biggest drawbacks that we have with most of our prandial insulin. So as we can see, the normal profile, the sharp peak and rise, the sharp rise and fall in the postprandial, just going to see, yeah, great. So as we can see, the sharp rise and fall of that initial insulin secretion that we have is never matched, or is almost always never matched by our prandial insulins that we have so far available in our practice. At the same time, we know that the injection meal intervals are also challenging. That is, most of our prandial insulins, there is this asynchrony between the prandial and the peak and our carbohydrate uptake. There is also data to show, now this is very interesting data, because this is what is the crux of the matter. This is clinically very relevant. So this is data to show us the challenges from the physician's point of view and the patient's point of view with the prandial insulins that we have today. So from the patient's point of view, and what I'd like to sort of highlight over here, thank you, is the fact that most patients, 82% of patients, are worried about their postprandial blood glucose, and they find that the pre-meal insulin has a negative impact on their quality of life. They find that it is negatively affecting their lifestyle to a great extent. And I think this is very practical, something that we see in our clinical practice very often. How often do we find, see, we are sitting at the other end of the table seeing our patients for 10 minutes in our consultation. And so simply, we just write these complicated regimes with the insulin to be taken half an hour prior to the meal. How practical is that? Or even 15 minutes prior to the meal or 20 minutes prior to the meal. How practical is it? The last point that you see over here, the second point, that most patients find that it's difficult to even eat out. Of course, eating out is not the priority, but to time your meal with that insulin is not practically possible every day of your life, isn't it? So this is one of the challenges that most patients face. And of course, physicians also do realize that this is a major challenge. More importantly, in this particular survey that was done, it was found that majority of patients do not take their insulin as advised to take, the timing of the insulin or the prandial insulin. So what that means is most patients end up taking their insulin either after the meal or just once they start eating and they've forgotten to take the insulin, so they take it in between the meal, which is probably a practical problem that most patients face, isn't it? So 44% of patients say that they take it immediately before meals. 24% of patients say that they take it after their meals, right? So this is a major challenge with most of the prandial insulins that we have today. So the gaps in the prandial insulins that we have, to sort of reiterate, is that one, the onset of action does not match the physiological peak of insulin, first phase of insulin, does not match the carbohydrate absorption, and the PK/PD also does not mimic the physiological insulin secretion. So that being said, what would be the expectations if we wanted the ideal prandial insulin? What would we actually expect? The expectations or the tick marks for an ideal prandial insulin would be, number one, all these challenges that we just discussed. Number one, it should be closest to that physiological insulin secretion that we have. Number two, the insulin should match that carbohydrate postprandial peak. And number three, last but not the least, it should be flexible or patient friendly in terms of your timing of insulin dosing with your meal. Of course, last but not the least, also we want a lower risk of hypoglycemia. So what is this ultra rapid Lispro that we have today? So the ultra rapid Lispro is nothing but, it's a combination of the citrate with the prostacyclin analog. And what these both do, these components actually do, is that the citrate component, I'm actually going to move on to the next slide, which shows us elaborately that this is what you see on the left is plain Lispro, which we all know the hexamers go into the monomers and then that gets absorbed. But what we have with the ultra-rapid Lispro is the prostaglandin component and the citrate component, which increases the vascular permeability and vasodilatation. And this in turn increases the rapidity of the absorption, and which is why you get that ultra-rapid action with this particular formulation. So when does this actually peak as compared to Lispro? You find that the peak is about 11 minutes prior to the action of that of Lispro, where you, as you can see in the graph over here. Secondly, more importantly, not just does the peak come earlier, 11 minutes earlier, you also get a threefold higher reduction in the blood glucose as compared to your usual Lispro. So the advantage, what does that translate to when you put that into the clinic, is that the insulin can be taken at 0 minutes before the meal up to 20 minutes post meal, right? So that is where the flexibility, and that is the key to actually improving patient compliance. And when you have that onset of action prior to 11 minutes prior to your Lispro, you're also going to have the threefold reduction in that carbohydrate postprandial peak. You're also going to have effective postprandial reduction. So the previous slide was comparing Lispro to ultra-rapid Lispro. When you compare Lispro, so what about the other prandial insulins that we have today? The red that you're seeing over here is the ultra-rapid acting Lispro, which is 11 minutes faster, 6 minutes faster than your Fias, which is the ultra-short acting aspart. It is 11 minutes or about 12 minutes faster than your Lispro and almost 14 minutes faster than your aspart. So this is a comparison between the onset of action of ultra-rapid acting Lispro as compared to the other prandial insulins that we have today. And this also translates to a higher and an early postprandial reduction in the peak. Now, the next couple of slides, so we've looked at the onset of action, we've looked at the comparison of the ultra-rapid acting insulin with the earlier Lispro that we had. We've looked at the flexibility in timing, the PKPD. Let's now look at some clinical data. I'm going to run us through this and then I'll sum it up. So this was a double-blind treat to target multinational RCT in which patients with type 2 diabetes were randomized into two groups. One group had, and these are patients who were on basal insulins, who were added on with a prandial insulin, Lispro versus ultra-rapid acting Lispro, and then followed up over a period of time. At the end of the study, they found that there was similar HbA1c reduction, not statistically significant, but achieved targets similar between Lispro and ultra-rapid acting Lispro. But furthermore, what they did find was that the postprandial peaks were significantly lower, not just at 2 hour, but at 1 hour, 2 hour, 3 hour, up to 4 hours. That postprandial reduction is much more efficient with ultra-rapid acting Lispro as compared to Lispro. And of course, the next question would be the safety in terms of hypoglycemia. Hypoglycemia risk was also lower with ultra-rapid acting as compared to Lispro. The overall safety profile was similar between Lispro and ultra-rapid. So the key points from this particular study is that you have a prandial insulin, an ultra-rapid acting insulin, faster acting than your Lispro that we had earlier, which has an 11 to 12 minute onset of action prior to that of Lispro. You have a 3-fold reduction in that postprandial peak, higher than Lispro. You also have, most importantly, flexibility in the timing of the dosing from 0 to up to 20 minutes post-meal. I'm going to skip through this one. This is the point that we just discussed. So the flexibility that I discussed earlier from 0 to 20 minutes post-meal also has been shown to improve patient satisfaction. And this is data to show us that compared to other mealtime insulins, people who were on ultra-rapid acting insulin in a Japanese trial, they found that patient satisfaction was much higher with ultra-rapid acting insulin. In conclusion, your ultra-rapid acting Lispro is a newer formulation in which you have a quicker onset of action. We know that postprandial blood glucose reduction is a challenge quite often in our patients, as I mentioned, with our high carbohydrate content, and most of the prandial insulins that we've had available so far did not match the physiological peak of insulin secretion, did not match that carbohydrate postprandial peak. Today we have this ultra-rapid acting or ultra-rapid Lispro, which has an onset of action around 11 to 12 minutes prior to that of the regular Lispro that we had available, almost 15 minutes prior to the onset of action as compared to Aspart, and a 3-fold further reduction in the blood glucose or the postprandial peak. This in turn gives us that flexibility with the timing of the insulin with the meal. So for patients who find it a big challenge to time their insulin with their meal, this gives that flexibility from 0 to up to 20 minutes after the meal, which is quite a game changer for many patients. Thank you.